So, welcome to the Rudolf Virchow Seminar Series on Global Health, sponsored by our Rio Center for Global Health. We are very pleased to have Professor Lee Riley as our guest speaker today. And for those who don't know you, let me introduce the audience. Lee is the professor and head of Division of Infectious Disease and Vaccinology at the School of Public Health, University of California at Berkeley. Among his past positions, he joined the CDC, the Epidemic Intelligence Service at the CDC, and also worked for some time for WHO in India. Also, he's been a program director for several Epidemic Intelligence Service, for several training programs by Fogarty International. And his current research involves tuberculosis pathogenesis, molecular epidemiology of drug-resistant bacterial infections, and last but not least, infectious diseases of urban slums in developing countries. So thank you very much, Lee, for being with us this morning, and the mic is yours.
Muito obrigado por fora. Não falo português, mas eu gostaria de agradecer agora hoje. Agora, tenho que falar em inglês. Desculpe. Okay, so that was. So I'm going to talk about a subject that I've been actually doing for many years. As Eduardo mentioned, I was at CDC doing EIS, the Epidemiologic Intelligence Service. Do you know about this program? Okay. So in Brazil, you have a similar program called EpiSUS in Brazilian, where you go training to do practical epidemiology. So it was during my EIS period that I was invited to Brazil for the first time in my life. So that was more than 30 years ago. And I went to São Paulo, in the School of Paulista. And I was asked by Professor Trabuzzi, Luis Trabuzzi. Some of you know him. He passed away several years ago. But he is probably the most important microbiologist in Brazil. He wrote the textbook for microbiology that's used in medical school in Brazil. But anyway, so he was doing a project on diarrheal diseases. And so I was asked to help him with the project. And I quickly learned during that time that most of the children who had diarrhea were coming from what I learned the term favelas in São Paulo, slum communities. And then I went away back to the US for a few years, and then I joined Cornell in medical school. And Cornell has been involved in research in Brazil for more than 50 years. And so when I joined the faculty at Cornell, I came to Brazil again and started my own projects. And I started working with tuberculosis. And I learned quickly that tuberculosis is also a disease that predominantly occurs in slum communities. And then we started working in Bahia. We started working actually on TB, but then we learned that in the process of studying tuberculosis, there were this set of illnesses where people came into the emergency room with liver failure and kidney failure, and they were obtunded. And we learned quickly that these are cases of leptospirosis. And again, leptospirosis is a disease that predominantly occurs in the favelas of Salvador. And so many of the infectious diseases that we always worked on were always diseases of urban slums. And so we decided maybe we should, instead of focusing on diseases, we should focus on the slums, the communities that determine these diseases. And so we've been doing this for many years now. And this new idea that I'm going to talk to you about is, how do you assess disease burden? How do you quantify the burden of disease when they occur in these informal settlements? Okay. So this is something I want you to think about. And then in the process of doing this, I'm a doctor, as Eduardo mentioned, but I don't see patients anymore. But when I see certain conditions, what do I do? So there's always a dilemma between or feeling that I have to do some action versus doing research. So research versus activism. And that's always a existential, I think, crisis that, when we work in us face. So this is something that I will discuss at the end when we have a discussion session. So what is this? Well, everybody knows Ebola, right? And so one thing that, we wrote a little brief communication that we sent to Lancet Global Health. And the title of this communication that we wrote was Ebola, Elephant in the Room. You know the term elephant in the room in English, right? So, how do you say the same thing in Portuguese? Same? Same? Amazing. So elephant in the room is the fact that, you heard all the discourses, right? All the discussions about why Ebola exploded in West Africa, right? So if you look at the, you can see the numbers here, but it goes, the first outbreak of Ebola occurred in 1976, okay? And there were many small outbreaks, but here in 2014, this is what happened. So what happened? Well, everybody says, oh, because of the war, because of the cultural practice, they wash the body when somebody dies, just because of poverty. But those have already been, those already been occurring for many, many years. That's not the reason. Okay? The reason is because this is the first time this virus has entered these urban populations, okay, in the slum communities of these cities. Nobody talks about this. And that's the elephant in the room. Okay? So if you look at the population growth of Sierra Leone, okay, over a 30-year period, it triples. And this increase in population tripled, and that produces conditions like this. When a virus like Ebola enters conditions like this, of course it's going to explode. It's obvious. But nobody talks about this. This is the elephant in the room. So this is the conditions. WHO got blamed because everybody thought WHO acted too slowly. CDC got blamed because they said CDC acted too slowly. No, even if they were perfectly, they did everything right, this would not have been prevented. This is impossible to prevent what happened. Okay, there's no blame for anybody. The blame is the fact that the society allowed these kind of conditions to build over time. That's the blame. It's not WHO, it's not CDC, it's not anything. So, how many of you have been to India? Most have been to India. Okay. So this is if you go to Chennai, India, which is an old name, it's a new name for Madras, the eastern side of India. If you go into the city at night, okay, from the airport, you'll see there's a river here. Okay, there's a bridge here. If you go at night, you'll see this. Okay, hold on, this off. Bottom. But anyways, so if you go, so you think that if you go into India, you think that this is what India looks like. Okay, no, this is how many Indians live. It's okay. But it is true. In India, yes, there's about 200 million people who do live like this. The middle class of India is the same size as the entire population of the United States. Okay? So yes, there are a group of people like this. But if you go across the same bridge at night, in the daytime, this is what it looks like. Okay? This is the other side of India. So this is often hidden under this kind of billboards, and we don't often recognize what's going on here. Okay? Now, this is India, but this is where? This is São Paulo. It's not that different. You have people who live here, and people who live here, and I think many of you have seen this photograph, right? This came from a revista journal in Brazil. It's a Harvard Review of Latin American Studies. Okay, so you have this fence, a very small fence that separates community like this, community like this. You have swimming pools in every floor. You know, even by American standard, this is really extreme as well. And so I study infectious disease. And if you study infectious disease, people who live on this side, yes, you see acute respiratory infection, TB, AIDS, STI, you see those. And you see the same diseases on this side. But you see these diseases that you will never see on this side, or rarely see on this side. You have leptospirosis, meningitis, hepatitis, vaccine-preventable diseases, MDR-TB, rheumatic heart disease, and here I have advanced cervical carcinoma. Okay, as you know, cervical carcinoma is caused by HPV, infectious agent. And why do you have advanced cervical carcinoma on this side and not on this side? Because, right, exactly. So they don't go screen, they don't get screening, right? They don't get pap smear, right? Whereas women on this side get pap smear, they're screened every year. Women on this side will never get pap smear, okay? So they get advanced form of cervical carcinoma. So you see, just in this study that divides these diseases from these diseases, and they live right next to each other. And how many of you have seen this? This is a very important report that came out about 10 years ago. It's called Challenge of Slums, Global Report on Human Settlements. Okay, this is a comprehensive report about the conditions of about 1 billion people in the world who live in these conditions. So there is an operational definition that the United Nations use, or human settlements use. So inadequate access to safe water, inadequate access to sanitation and other infrastructure, poor structured quality of housing, overcrowding, and insecure residential status. This is the definition. It's the official definition that the UN uses to define slums. You know, the word slum, maybe 10 years ago was somewhat pejorative. Just like in Brazil, the word favela is somewhat pejorative, right? And of course, it's interesting that the word favela, the pejorativeness seems to vary from different parts of Brazil. So in Salvador, we don't use the word at all. It's not very polite. We say comunidade. In Rio, it's a little more accepted. In São Paulo, it's a little more accepted, but they have many different terms. So I don't know, sometimes I don't know how to say that, but so I'm going to use the word slum. So in the world, 1 billion people, as of 2003, lived in this. Now, that was 10 years ago. So maybe it's more now, or maybe it's less. But 1/3 of the world's population live in this kind of condition. They estimate that by 2030, this would be 2 billion. So, right, in 2003, 43% of combined urban population in all developing countries were already living under that condition. In the least developing countries, almost 80% were already living in that. In Sierra Leone, in the Freetown in Sierra Leone, was 90%. 90% of the city of Freetown, Sierra Leone, was considered to live in urban slums. Okay. So that's what happened. Okay. So this report studied demographic, spatial, economic, legal, and social indicators of 1 billion people. They also studied or reported life expectancy, under 5 mortality, access to improved water source and sanitation, slum upgrading program, poverty reduction programs. What do you think was missing? So they did all these things in the report. You can read about this in that report, but you cannot read about what's missing. What do you think that is? Exactly. Health burden measures. Yeah, this was completely missing. And of course, it's missing because it's not easy to do this. It takes a lot of resource and effort to really come up with measuring burden of disease. So how do we learn about burden of disease? In places like here or in the US, how do we get formal information about burden of disease? If you want to find out how many TB cases occurred in Rio in 2014, where do you go to get the data? Or how many people are under, they get the monthly salary of less than 1 monthly salary, minimum salary. Where do you go to get the data? For TB here, you can go to Sinan, right? Well, Sinan database, surveillance system, and get the information, right? So Brazil has a nice formal surveillance system. So you can also get national mortality rate. You have that here. You have the census bureau here, right? You can also go to the hospital, get hospital discharge, health insurance database, right? Although here you have SUS. You can get information from SUS, but you can also get private insurance database. Demographic and health surveys, multiple indicator, WHO surveys, and then global burden of disease reports, right? The GBD. This is done by the IHME in Washington, right? They measure disability adjusted life years, DALYs, YLL, YDL. And the most recent GBD report was summarized in Lancet in 2012. Have you read this? Right, so you know about this. So the last surveys examined 291 diseases and injuries from 21 regions, 20 different age groups. They also looked at 67 risk factors for DALYs. So they included as risk factors inadequate access to safe water, inadequate access to sanitation, other infrastructure. These are the 2 of the 5 components of the definition of slums. Okay, so they included these risk factors as part of the 67, but they did not include the other 3 components of the definition. They did not include poor structured quality housing, overcrowding, and insecure residential status. So even the most comprehensive burden of disease did not include these as risk factors. If you don't include these as risk factors, what happens? What disease would you miss if you don't put poor structured quality of housing? What would you miss? And what happens when you have poor structural quality housing? Yeah, overcrowding, you have many types of disease, so the respiratory transmitted, you miss those, right? What about structural quality? Okay, so you've seen these buildings that they put in these poor communities, right? They have these vertical structures, and there are very little spaces for children to play on the ground, right? So they go to the top, they play on the top, and they fall, and they injure them, children. Okay? The adults, right? They don't have a place to hang out. They go to the roof, they get drunk, and they fall. It's very common in Brazil. Okay? In the types of infrastructure of buildings you have. In Salvador, it's the same thing. Vertical structures, you can have open space at the top, falling injuries. Okay? That's not included in these 291 injuries. Okay? Because they missed this risk factor. Okay? Insecure residential status, what happens? What kind of diseases do you see?
Violence.
Yeah, violence, exactly. Yeah, the answer was right. So interpersonal violence, right? And violence to women. Okay, it's a huge issue. And those are not included. Okay, so this is the report from for Brazil. This is the DALYs. So in 1990, you've seen this, right? I think everybody's seen this. If you have not seen this, it's very important. Because in 1990, in the 1990 GBD report, these are years of life lost in thousands. The most common cause of YLL was lower respiratory infection, and then preterm birth complication, diarrhea diseases. Okay, these are all infectious disease, right? Related infectious disease, and they dramatically decreased 20 years later. But look what happened. The number 1 cause of YLL in 2010 is interpersonal violence. Oh, YLL is years of life lost. Okay? So, the disability adjusted life years, DALY, is the sum of YLL, years of life lost, and YLD, years of life living with disability. Okay? So YLL is let's say you have tuberculosis at age 20. Okay? You die of TB at age 20, but the theoretical lifespan of a human being, Homo sapiens, is based on the mean age of Japanese women, mean age of death and the lifespan of Japanese women, because they live the longest on this planet. Okay? So theoretically, every human being should be able to live at least to 88 years. So if you die of TB at age 20, you lost 68 years of life. You understand? And so that's how you class it. So these are the most important causes of death. They are contributing to YLO, and they all went up. But interpersonal violence is now the #1 cause of YLL, okay, in Brazil. Now, then you have this chronic disease, ischemic heart disease, stroke, road injury. Number 5, infectious disease is down to number 5. Okay, that's the most respiratory preterm complications. Diabetes went from number 17 to number 7. This is an epidemic. Okay, this is what's happening. So, see how it changed over time. But this interpersonal violence is largely because of the growth of the informal settlements in many cities in Brazil. So in Brazil, I've been working in Brazil for many, many years. Of course, most of my projects related to infectious disease. So we study diarrhea disease, leptospirosis, tuberculosis, rheumatic heart disease, and then this is what we're doing most recently, slum-specific disease burden assessment. So in Salvador, of course you've all been to Salvador, right? So this is Pelourinho. This is what it looks like. I don't have to tell you about this. But we work in one community called Palo Lima. You know, have you ever been to Palo Lima? You know, it's near the airport in Salvador. In these are 1950s. This is a typical Atlantic rainforest area. We have these hills and valleys. And then by 1970s, we begin to see formal settlements here outside. This yellow area is an area that we've been studying leptospirosis for many years. Okay, and it's collaboration with Albert Koch, who was my infectious disease fellow. He sent him to Brazil to study this, and he lived in Salvador for 15 years. And he's an American, but he lived in Salvador for 15 years. And so, so in 1970, you don't see any housing, but by 1989, you begin to see these slum communities inside this area. And by 2002, it's completely covered. Okay? And if you look close, this is what it looks like. So it's a valley, okay? Many of the houses here, and then in the lower part of the valley, you see this little creek. And then during the rainy season, water level comes up to here. So people have to walk through this. If people walk through this, you know how leptospira is transmitted? So leptospira is a type of spirochete. It's a bacteria. It's a spirochete. It's excreted by the rat urine. Okay? So rats, lots of rats, and they urinate in the water. The water contains the spirochete. So people walk through the water. The spirochete goes through the skin, goes into the bloodstream, disseminates all over your body, goes to the kidneys and liver, and shuts down your kidneys, and you die. 15% mortality, no matter what you do. But it's a very easy disease to treat, but you have to start the treatment very early. You have to give very cheap, simple antibiotics, and you can treat it. The problem is, during the rainy season, as you know, here in Rio also, you have dengue, right? So the clinical manifestation of dengue in the beginning is very similar to the clinical manifestation of leptospirosis. With dengue, you don't use antibiotics. So people don't get treated. If you don't treat leptospirosis, you die. So that's what happens, okay? So one of the first things we did was to try to develop a new diagnostic test, a very rapid diagnostic test that can distinguish dengue from leptospirosis. And we now have this. It took more than 10 years, but we have this product. And it's actually going to be produced by biomarkers here in Rio. Okay? The idea is if you try to develop this test and then give it to some American or European company, they would make the test so expensive that it would not be affordable. So we negotiated with Brazil, biomarkers, so they can make the test here. Okay? And the test will, of course, be made by a small company in the US, but they negotiated with biomarkers so we can make it affordable. So that's something that we were able to do, and I think this should be commercially available for Brazil and other places maybe in the next 2 years, hopefully. But I don't want to talk about leptospirosis today, because I want to give you this concept of assessing disease burdens. I want to talk about rheumatic heart disease as an example. And you know rheumatic heart disease? how many of you are physicians? Okay. So some of you are physicians? Again, no. Okay. So physicians know rheumatic heart disease. So rheumatic heart disease is a type of, is very rare in the US. It's rare in one type of population in Brazil, but it's not rare in the other type of population. You know, the people who lived on the left side of that fence is common. People who lived on the right side of that fence, very rare. Okay. In the world, about 15 million people live this, have this occur. There are 15 million prevalent cases, and about a quarter of a million new cases that occur. About the same number that die every year. It varies from 0.2 per 1,000 in Cuba to 78 per 1,000 in Samoa. It's responsible for 12 to 65% of hospitalization for cardiovascular disease in developing countries. And it's now the leading cause of valvular damage in surgery in China. And the prevalence is significantly higher in terms of living in urban slums. So that's what happens. So this is a disease. You know, everybody in this room has sore throat, right? Caused by group-based streptococcus. But if you get recurrent infection with group-based strep, it induces an autoimmune response. And the autoimmune response starts damaging the heart valve. Okay? The antibody will target the bacteria, but there are proteins in the valve that are very similar to the bacteria protein. Okay? So the immune response then starts damaging the heart after many years. And so the valve has to be replaced with artificial valve. Okay? And it's very interesting. So so Brazil, just in São Paulo, they spend about $50 million a year replacing the valves. Okay? Now, you can prevent this problem for less than $1 million a year in Brazil. Just give antibiotics. Cheap antibiotics for the sore throat. And then you don't have this problem. But it doesn't happen because these children live in urban slums. Okay, so it's caused by group-based strep. Now, in the past, WHO estimated that the prevalence peaks at young adult age. But my collaborators in Salvador, Brazil, cardiologist Dr. Kumara, studied rheumatic heart disease, and in Bahia, the mean age in one study was 12 years, and he did another study, the mean age was 9 years. These are children. These children are developing congestive heart failure and stroke because of the valve disease. It's really like, you know, just unheard of. This is what it's supposed to be. But in Salvador, it happens with little kids. And then when their valves get replaced, they're so young. When they get maybe in their late 20s, 30s, they have to get replacement again. And so this is a huge, huge problem. But you don't know about this, right? You have not heard that this is a problem. So, as I said, it's caused by group-based strep. And in the past, these EMM types, A through C was associated with sore throat. Type D was associated with skin infections. Type E was associated with both. This is what, when I went to medical school, this is what we were taught. Okay? I think it's being taught now in medical school. But in more recent studies from Australia suggest that these are not true. That there are no association with EM types with these outcomes. Okay? That is different. So these are so-called rheumatogenic strains, but it's not observed in recent studies from Southern Hemisphere countries. So we decided to do a study in Bahia, okay, see what's going on. So EMM is a gene that encodes outer membrane protein called M protein. Okay, and you can use this to type the different strains that we use. Or you can also do what's called multi-local sequence typing. It's a way to genetically subtype the bacteria. And so EMM is based on the N-terminal hypovariable region, okay, protein N. Now, in the world, the most common EM types are EMM1 and 12. Okay, that's what's reported in the literature. Higher diversity EM types are observed among group-based strep from African and Pacific region countries compared to high-income countries. So this is the review by Steer in Lancet that appeared about 5 years ago. You see this? So the red bars indicate the EMM type that's included in an experimental vaccine. Okay? The green ones are not included in the experimental vaccine. So if you look, you see this? You have EMM1 and EMM12. Okay, so they included the most common EM types in the vaccine. Okay, and these two are account for about 35%, more than 35% of the EMM types that are found in high-income countries. So this vaccine will be good, very useful in high income. Now, they discovered that in the African countries, yes, you have EMM12 here, but EMM1 is here. Okay, EM1 and EM12 will be maybe 10% of all of the EMM types in Africa. So this vaccine will be less effective in African countries. If you look at Pacific region countries, EMM1 is 1 here. There's no EMM12. So this vaccine will be totally useless in Pacific countries. Okay? And so you see how this product was developed. It was developed with high-income countries in mind. Now, high-income countries do not have rheumatic heart disease, so it's not going to be all that useful. Okay? This kind of vaccine is needed in places like Brazil and Africa and Pacific region countries where there's a high prevalence of rheumatic heart disease. But this vaccine would not be useful. So we did this same study in Salvador, Brazil. This was a study done by Sarah Tartoff, who was my PhD student from Berkeley. She spent 2 years in Salvador. 3 outpatient clinics. There were 2 clinics that served the slum residents. One is called San Marcos, and the other is called Centro. And then another clinic, was a non-slum, privately insured residents clinic called George Valenti. This study was done in 2008. We studied children with pre-15 cases with children with chief complaint of sore throat, controls with children with other complaints, not admitted to the hospital. So this is San Marcos, Centro, and George Valenti. And then Palo Lima, I told you, is right next to San Marcos. So San Marcos is the clinic that serves the Palo Lima people. In Centro and George Valenti, they're very close to each other, less than 1 kilometer. Okay. And the reason we did Centro is because Virchow, which is the place I work with, is located here. This is what we found. So George Valenti, the symptoms diversity index was 0.92. In Centro, it's 0.97. In EFM, 96. You see, the diversity index is higher in the favela clinics than in the private clinic. And look, this is the STEER Lancet study, 92%, identical. Okay, and look, same city, but the diversity index of the rich kids are the same as the rich kids in North America. Okay, the diversity index of the slum kids are the same as the kids in Africa and Pacific region countries. Why? Same city. Okay, so if you do the same plot, look at this. This is George Valenti, 12 and 1, EM 5, 12 and 1. Okay, so it's like 30, almost 35%, just like high-income countries. But if you go to emergency San Marcos, 12 is here, 1 is here. This is about 21%. Quito Centro, 14%. So, this was very surprising to us. Okay, that in the same city, if this vaccine became available, yes, it will be effective for the kids who go to Olympic, but it will not be effective, very effective for these kids. So this is what I mean by doing biology, that you have to do biology to really understand disparity. So this disparity, we always talk about social disparity, income disparity, injustice, social injustice, but there's already a disparity at the biological level. Okay, that's the problem. So you can talk about reducing poverty and all those things, but if you don't do something about the biology, we will never solve the problem. So in Berkeley, we really try to emphasize biology. Okay, you have to understand this at the cellular level. Okay, of course, it's important to talk about social disparity. Okay? It's important, but you have to always remember that if this vaccine was produced, it would not have been useful for these kids in the same city to have this unequal effectiveness in the same population. Okay, the same thing. So now, Rio. So you don't need to talk about this. So the reason we did this work in Rio is because of the World Cup and Olympics. I know you don't want to talk about the World Cup. Forget that. I'm sorry I brought this up. But some of you know, did you know this? Did you know about the Street Child World Cup that was also held in Rio in April? You did not know this? So 2 months before the World Cup, there was a Street Child World Cup here in Rio in April. Okay? They came from about 20 different countries in the world, street children. Okay? They competed. And it actually included boys teams and girls teams. And you know who the boys team won the World Cup? The final match was between Burundi and Tanzania, and Burundi won. The girls team, the final match was between Brazil and Philippines. And who won? Brazil. The girls redeemed what the Brazilian male team did not do. Okay, so that was good, right? The Brazilian girls team, street children, became the world champion. So you know about these UPP, right? So I won't go with that. So what we wanted to do was, what is the impact of UPP on different disease burden? So we wanted to quantitate the impact. Okay. So we wanted to develop what's called a some-specific metrics to calculate DALY gap. So DALY per capita for TB low and middle income is 0.007. DALY per capita TB high income is 0.002. So DALY per capita TB is 35% greater in low and middle income countries. So we wanted to do the same thing with subpopulations in Rio. So you know this, right? You know about this? Models of the mice. This is the new definition of favelas that the Brazilian government uses. Okay, this was so these are settlements with at least 51 houses, illegal occupation of land, possessing at least one of the following: urbanization outside of existing standards, lacking essential public service, invaded land, irregular and illegal lots. And so this is a complex element model. You know this. It's not that far from here. And so you can see that it's kind of the historical development of the favelas. You know the word favela, where it comes from, right? I shouldn't tell you. Favela, it's during the Canudos War, right? The federal troops, they're not very good troops. They were defeated 3 times, and finally they won. But the last troop, they were staying on when they defeated the rebels in the Canudos War, the soldiers came back to Rio, okay, and then waited in the hill to get paid. And they waited and waited and waited, but they never got paid. Okay. So they became known as the favelados because in the Canudos War, where they defeated the rebels, there were all these small trees, and they're called favelas. It was the name of the tree. Okay. So these soldiers became known as the favelas. That's where the term comes from. Now you know. But anyway, so this is a kind of the way these communities develop. So here, these were different. I don't know when these were built, maybe 1950s, 60s, right? So this failed because this disrupted the social network, right? So Brazil is one of the best places to study urban development. So people from all over the world come to Brazil to study how they deal with these informal settlements. Brazil has done many, many things. They are leaders of the world in trying to deal with this issue. Even though they have a problem, they also know, at least try to make attempts to do something. Okay? So if you look at TB, in Rio de Janeiro, the incidence per 100,000 was 120 per 100,000 in 2005. In 2010, it went to 116 per 100,000. In the US, in 2010, it was 4 per 100,000. So it's still very, very high. Okay? But you can see the incidence decrease, right? So you say this is good. Brazil is doing something right. Oh, are they? So if you look at the daily causeway TV, it's about 50 million in the world. In Brazil, it's 270,000. It's about 142 per 100,000. In Rio, it's 265 per 100,000. Okay? In Aglomerados do Mais, it's 306 per 100,000. So, in the non-AGSN, 236. So it says here, the gap is 70 per 100,000. Okay? So there's a big difference. Not, 70 may not be big, but if you look at it, okay, yeah. But look at this. So we stratify by age and gender. And the black ones is the Daly gap. The purple is the AGSN, and orange is non-AGSN. Okay, so these are the Dalys. So if you look at the 40 to 59-year-old males, in both AGSN and non-AGSN, the Daly for TB is 850 for AGSN and about 500 for non-AGSN. The gap is black. But you see this? In the young adult male, 2039, is reversed. Why? This means that the value for TB is greater in non-AGSN than AGSN. It's not true for the females. But here, this is reversed. We couldn't understand this. Do you have some ideas why? Huh? Exactly. Yeah, these kids, these young adults are in jail. They're all incarcerated. We don't have their address. We don't know if they live in AGSN or not AGSN. This is why it's reversed. So you can see the impact of violence, right? That this is what's going on. That we can't even accurately assess TB down because they're in jail. We look at the YOD gap. And now I showed you the incidence decrease, right? But if you look at the subpopulation, for instance, less than 1 year of age, in 2005, here's the gap, and it increased over a 5-year period. Okay? Even though the incidence decreased, the gap increased. So this means that in infants, the TB has increased in the favelas here. Okay? And this is very important because I do a lot of TB work. When you see TB in children less than 1, that means that's a good marker for a very bad TB control program. Okay? Because what happens with TB? When you get infected, if you're an adult, some people rapidly develop disease, but most people will not develop disease for many years. Okay? But by definition, if you have TB less than 1 year old, that means the infection recently took place, right? By definition, the infection was a recent transmission. That means that the program, TB control program, is not preventing new transmissions. Okay, so if you have high incidence of TB in less than 1 year old, that's a good indicator of the quality of the TB control program. Yes. There should not be. In fact, there should be 0. Because if you have 1 case of TB in infants, that means transmission is occurring right now. You're not preventing it. Okay? And you can see that in some other age groups, gap also increased. So the Daly gap measure, this metrics, gives you a much more refined way to analyze the burden of disease. Okay? If you just looked at incidence, it doesn't give you that kind of. Of course, you can do age-specific and gender-specific incidence. But I'll show you some other data. This is just looking at the income, monthly income, and census tract. So the orange is the non-AGSN, purple is AGSN. You can see TB in the non-AGSN is all across the income. Okay? Whereas TB in the low income is limited to less than 1,000 per month, 1,000 reais. Oh, these are US dollars, $1,000. And the TB value gap between highest and lowest income group was 323. So just looking at more subpopulations. So I told you the total TB DALY in real was 265. Living in AGSN contributed to about 1/4 of this DALY. HIV infection contributed 36%. Incarcerated and homeless was only 4%. Males, 500, in this age group, 500. Females, 169. If the community had less than 60% electricity, it's 12,000. It's a huge number. I don't know why electricity is contributing to TB down, but this is what we found. Maybe it's a marker for poverty, I don't know. Sanitation service, same thing. Clean water, 467. 70%. Solid waste disposal coverage, 600. So now I want to show you and give you an example of why incidence is not useful. So there are two neighborhoods in Copacabana. This is Cantagalo, right? Cantagalo in Copacabana, But here you have a community like this, and you have buildings like this. In 2010, there were 15 cases of TB in Cantagalo. Okay, the monthly income of this community is $423. Population was 1,600. So 15 cases of TB is incidence of 908 per 100,000. Now, 1.5 kilometers, this is non-AGSN. Monthly income is 2,189, population of 237. But there were 22 cases of TB in this community in 2010. Okay? So incidence is 9,283, 10 times more in this community. But the DALY for 100,000 was 3,400. So DALY for 100,000 is here. It's about 9,000. Okay, for 100,000. So the DALY for 100,000 was much greater here than here. Okay, so yeah, because they die early. If you have TB here, you die early, so you lose more. Okay, so incidence is not a very useful. If you use incidence as your measure of burden of disease, then you say the government, oh, let's do something here. Okay, but if you do the DALY for 100,000, this is where the problem is. You understand? So that's why DALY gap is a better measure of what's really going on than the measure of incidence. And this is what we want to do with other diseases, to really develop these new metrics to understand disease burden. Okay, instead of just the typical, usual, conventional measure of incidence. Oh, okay, here. So the difference was 4,547. It's a huge difference. Okay, so we also did a heat map of different census tracts in Lyon. Okay. So this is Copacabana here, and then we looked at, so the deeper color is, this is 500 and more, a value of 500 and more. And you can see that even in the non-AGSN census tract, you also had 500 and more. So most of the, this is complex automat, no, it's up here. This is Copacabana, and this is Ipanema. Here, this area, right? This is Messina. No, I'm sorry, Messina is here. And okay, so even Messina, there are different gradients, concentration of TB. And here's the highest density of TB gallons right here. So last December, I visited here and with my students. And we found on the street, it's a Rua Segundo, there was a TB clinic. And we think this is why there's so many TB cases. So maybe the people who live near this area go to the clinic, so more likely to be diagnosed, right? So they access to the clinic. So the point is, it's okay to do all these calculations and sitting in front of the computer, but if you don't go and see what's going on, then you don't really understand what's going on. So I always tell my American students and Brazilian students that don't just sit in front of the computer, go and see what's going on, right? So then you understand what's going on. So now let me just end by just giving this sort of idea that we have. So, we often talk about social and environmental determinants of disease. You have, of course, do this in this institute. And of course, in the School of Public Health in Berkeley, we talk about this, the social determinants of disease, environmental. And we say that they cause TB, diarrhea disease, AIDS, etc. But poverty and inequality and social injustice do not cause TB. Mycobacterial tuberculosis causes TB. Okay? Diarrhea is not caused by poverty. Diarrhea is caused by Salmonella, Campylobacter, E. coli, norovirus. Okay? Right? So we often do not discuss this one. It's a black box. And these social determinants of disease also have an impact on the biology. This is often not, this is understudied. This is what we need to understand better. I gave you an example of the disparity of the group-based strep, right? And then you can study this. And these also affect these conditions in reverse. So this is a cycle. Okay? But I think if we don't study this more, we will never be able to do this. And this is what we're trying to emphasize. Okay? So the original title of my talk was Slum Health from Cell to the Streets. But I thought I was a little too cryptic, so I changed the title. But the reason I suggested that original title is because another faculty member at Berkeley, Jason Corbin, who's in the Department of Regional Planning, City and Regional Planning, and I are writing a book. And the title of the book is Slum Health from the Cell to the Street. Jason Corbin is Guillermo's mentor at Berkeley. So Jason does more of advocacy work, slum development, from an urban planning and urban development perspective. And I do the biology study. Okay? So we think that this combination of approach to dealing with slum health issues may be, maybe a better way to really understand what's going on. And that way, this one book can be read by everybody. People who do social sciences, or people who do biology, understand what each other's disciplines are doing. So that's the idea. So this is the question. That was Hamlet, right? To be or not to be? Is it to do advocacy or to do research? This is something that we always have to deal with. Or biology versus social determinants of disease. So which is it? You can make a choice. But I think we need to talk to each other more. We need to understand more. We need to get biologists to really understand social determinants of disease, and social determinants of disease people to understand the biology. So before I went to Berkeley School of Public Health, I was in a medical school. So I only studied this. Okay? So I didn't know anything about this. But now I'm being forced to understand this. So, all people can still learn. So where do we go from here? So, we can't wait for alleviation of poverty, disparity, and inequality. We've been talking about this for thousands of years. We already know this. But do we wait forever? We can't wait for social capital development, technology transfer, UN Millennium Goals. We really have to do something now to formally recognize the existence of this fund. That's number one. I learned, from India that when somebody's born in a favela, in a slum, they're not even registered in many places. Okay? So if they're not registered, then they don't officially exist. They cannot get their Social Security or CBS equivalent. They cannot get insurance. They cannot get anything. They cannot go to school. Okay? So we have to know that they exist in this population. Then assess the burden of disease in this developing measures. We need to really quantitate what's going on so that people in position of influence can use the data to do something about the problem. they conduct research report findings in international journals. Don't just report it in some local journals. Nobody reads them. Just report them in international journals so everybody is aware, becomes aware of what's going on. Then provide data for national governments, identify equal and novel interventions specifically designed for SNOWs. And then get those in position and set the priority straight. I think this is an important point. We need to get the priority straight. So in the last week, we've been having very interesting issues, political issues. But nothing is a problem priority. What's the priority? Who said this? So this person said this about 2 years ago. He said, in any stock exchange, go up or down 3 percentage points. And this is a world event. This cannot be. It's time to flip the tortilla. Who said this? He said this in here. Who said it in Rio? Okay? When he was here, in Obama, he said this. Okay? It's time to flip the tortilla. Let's get this priority straight. We can't talk about stock exchanges. Let's talk about what's really important. I never quoted the Pope in my talk. But this Pope, I think he has a good head. So I want to end by telling you that in Berkeley, we have this training program. Okay, it's funded by the Authority Institute. Right. So Eduardo was actually one of the outside reviewers for the candidates. So they applied for this program. It's called Global Health Equity Scholars Program. And this UC Berkeley is the lead institution, but it involves Yale, Stanford, and Dakota International University. And these are all the sites these 4 institutions have to send U.S. postdocs and to work with local postdocs to do research related to strong health issues. Okay, so if you are a PhD student who finished the program, or you're a postdoc, you can apply to this program. We'll match you with an American postdoc to do a project. We'll give you funding to do research projects. So if you're interested, just look up Global Health Equity Program, and you can see it, all the descriptions. Okay? So these are the people who worked on these different projects. So Maria Malo is a postdoc under this program right now. She's American. She's working in Detroit right now. And then Robbie Snyder is a PhD student who's working in Detroit. Sarah, I mentioned, Eva Rafael, who also helped with the food-based strip project. And Brazil, in Salvador, with my base, that's crazy, and then Kia, the partner here. Then Victoria, who worked with a TB researcher at Del Maciel. And I was going to end by saying, don't throw these people away. I'll stop.
Nós temos cerca de meia hora para perguntas e comentários. Se alguém quiser fazer em português, eu poderia traduzir para ele em inglês. Não fiquem tímidos com isso. Quem tiver mais familiaridade, mais fluência em inglês, pode fazer diretamente.
Eu sou professor aqui da Universidade Estadual do Rio de Janeiro. Também trabalho no sistema de vigilância estadual de saúde. Então, acho que tem alguma visão também desses números por outro ano, certamente, e das publicações do grupo, que também a gente tem acesso. Deixa eu adicionar alguns pontos, né? O primeiro é a separação, nem sempre bem definida entre o que é o biológico e o que é social. Por exemplo, na questão específica da potencial vacina estreptocócica, né? Como a gente já faz com influenza, é básico a utilização de pesquisa para saber quais são os sorotipos, os serovatos, que são mais prevalentes de qualquer micro-organismo quando a gente entra com uma vacina que pode ser serotipo específica. Então, na verdade, isso aí é uma questão biológica de variação ou uma questão social de falta de interesse de pesquisa nessas áreas em diferentes pontos, né? Então, embora tenham coisas tipicamente sociais, tipicamente biológicas, algumas ficam numa área cinza entre o biológico e o social, que pode até ser questionável, essas questões especificamente biológicas. São muito mais por questões sociais que dificultam, que interferem com interesses outros específicos sociais de não ter pesquisa, por exemplo, em favelas, que especifiquem qual é aquela população, ou seja, a visibilidade daquela população para a indústria farmacêutica em geral produz esses produtos. A segunda coisa, né, é a questão dos cálculos, né? O GBD foi extremamente criticado por algumas formas metodológicas de capturar casos, por exemplo, malária na África, né? Quanto que há de questões metodológicas específicas, quanto que há discussões sociais específicas que envolvem falta de interesse em investir no GBD em outras iniciativas que tentam dar visibilidade, né, ao burden of disease nas áreas mais pobres e mais carentes, consideradas áreas negligenciadas. Eu queria apenas ouvir um pouco de você, quais seriam as... Como é que você vê isso? Como é que você pode aprofundar essa discussão, justamente para a gente até dar o que é social, o que é biológico, o que é no meio do caminho. Epigenética é um bom exemplo de coisas que são fenômenos biológicos, mas extremamente influenciados pelo social, intergeracionalmente. Como é que a gente pode também aprofundar essa discussão, trazendo tanto questões técnicas, metodológicas, quanto questões filosóficas, né, para essa discussão?
I think it's a good point. What is the interest on the part of industry to invest for vaccine development, right? In diseases like rheumatic heart disease. You're right, but you have to give some sort of incentive. Actually, there are two ways to answer this. There are two ways to answer this. One is, okay, for some reason in the world, there's this idea that somehow private industry has to develop a vaccine. Okay, and I think that premise is not necessarily true. Okay, so that's the bad, I think, kind of mentality that's got established in the world. That somehow private industry has to make vaccines. Okay, I think we need to drop that idea and say, I think it's also valid that government can develop vaccines for these kind of populations. And Brazil does. Brazil has the vitamin opinions. Okay, so they do, but that's not enough. Even in Brazil, most of the effort is towards private. It's going away from the government. But in the U.S., this concept doesn't even exist. People just naturally assume that it's the industry that has to do this. But I think that premise is wrong. So if we drop that premise, then there is an opportunity to develop a vaccine, this kind of vaccine, for these vulnerable populations. But if we have to use the industry, private industry, multinationals, then we have to give them some sort of incentive for them to do this. For instance, they're developing vaccines against TB. Lots, billions of dollars have been spent in trying to develop a vaccine against TB. AIDS, right? Because there's some sort of, I think they see some sort of benefit. The group of private industry got together to develop a vaccine against Ebola. Okay, that was done. So sometimes, they do show some interest. I'm sure there's some sort of ulterior motive, but if you sort of convince them, I think they can do this. But if they were to do this, we need to provide them with the correct data that's focused on these populations, such as the difference in the genotypes, okay, the group-based track. So you can't just tell them to develop a vaccine because it's socially responsible. It's not enough. You have to say, this is the data, this is the biology data. You have to use this biology data for them to develop the right vaccine. Okay, so that's what I'm saying. So it's important, so you have to understand the social determinants of disease, but at the same time, use that information to study the biological determinants of disease as well. Combine those two to then tell industry to develop the right appropriate vaccine. So that's saying that, malaria and other diseases happen. There's a lot of effort, a lot of money being spent on malaria vaccine. There's a lot of interest. Okay? So, I think, if you can somehow try to, the science is very interesting, right? There's a lot of people interested in developing malaria vaccine, AIDS vaccine, etc. Because the science itself is very interesting. The scientists can then convince the vaccine makers to really get involved. And I think you can somehow, try to convince these people who are in the position of power to make these vaccines appropriate, I think can be done. So, but you have to do both, understand the social determinants as well as the biological determinants to do this correctly. So that's the point that I was. It's not that you can't separate them. You have to.
Bom dia, good morning. I'm Mia. I'm from the Department of Surgery. I'm a professor of surgery. I came here by accident. It's very good to. I came for a class actually. I'm a PhD student from the Faculty of Medicine. I also am professor and assistant professor of surgery. And you introduced me. I'm very familiar with quality, but I never heard of daily. And I'm very interested right now at the moment. I never saw the daily metrics for surgical events or surgical populations. So my question is that as a measure of disease burden, and we work on cancer, so we do disease burden all the time, but I never heard of the daily metrics. So my question is, do you have an experience or any lines of research that do metrics for surgery or surgical events, specifically using daily?
Yes. So the 2010 Global Burden of Disease, they actually do take into consideration. So the as I mentioned, the DALY is a sum of YLD, and YLD is the years of lived with disability. So people who undergo surgery have certain disability, right, after the surgery. And so, especially like the low back pain, that actually contributes a tremendous amount to YLD. And people who undergo surgery for low back pain has very high YLD assignment. So surgical procedures are used to weigh, they give a certain weight to the burden of disease. So you can study that it changes for different surgical procedures. So I don't know off the top of my head, but there's a table of certain weights. So you multiply the weight due to the surgery times the disease, the number of disease, and then calculate the number of years, of disability. That's how you calculate the YLD. And then we also, in Salvador, we actually tried to use surgery as a way to assess disease burden from rheumatic heart disease, right? So when you do the study the prevalence of rheumatic heart disease, it's very difficult because, unless they exert themselves or do something, you can't really know if they have it, right? Or you can do echocardiogram, you can do an echocardiogram surveys, but it's very expensive to do this. So what we did in Salvador, we asked all the cardiac surgeons in Salvador. There are, I think, there are many cardiac surgeons, but there are only 6 hospitals that do open heart surgery in Salvador. So we talked to the cardiologists who did open heart surgery, and reviewed their logbooks. We asked them, how many surgeries did you do on the valves? And we got the information. And then we looked at so there were about 60% of the open heart surgery was due to the valves. Then we reviewed the charts. And we found that more than 65% of the valve surgery was due to rheumatic heart disease. So we have to use the surgical information to really understand the burden of rheumatic heart disease. And if someone requires surgery for valve, for rheumatic heart disease, that's only a tip of the iceberg, right? That's a advanced form. So by knowing how many people get the surgery, you can estimate the burden of the non-surgically required rheumatic heart disease. So that's how we came up with the information about the burden of rheumatic heart disease itself. So we have to use the surgical
The question of value, well, in my view, I'm not able to explain well this. It's very hard to see policymakers or decision makers in health to use this concept of the data to make decisions, to decide the priorities, the allocation policy. And I think the example that you gave on TB, Copacabana in Catagal was wonderful. But you consider that if you make a decision only based in incidence, you are making a huge mistake. And this was probably one of the issues that you have been discussing the center that you started to organize. How you combine the research, as everybody said, the research with the training programs, but also with some advocacy work. But here, I think it's an issue that clearly, I don't know, well, I've been here, I have not been here for quite a while, but I asked the Secretary of the State or the health or the municipal health department, nobody takes decision basically in this type of argument and you state that is, when I was in WHO, this was an issue. There's a huge resistance to, well, there are methodological issues, certainly, but basically it's a change in the, let's say, mindset with how people would use this to make decisions. So maybe I think the example that you gave is brilliant, but can help a lot. I think even the people who develop the global project Brazil have some trouble to make the point on that. This, I'm not an artist, although a long time ago I did something, but I think from planning, policy, make decision is quite important. I don't know if you have a comment, otherwise you can.
I agree. No, trying to convince the politicians based on data sometimes, in the U.S. It doesn't often happen. But there are some other ways.
Well, first, my name is Cristiano. I am former professor of the Rio de Janeiro State University. Now I'm at Fiocruz as well, the Cruz Foundation. First of all, congratulations, Eduardo, for holding this excellent series of presentations that I think is very, very important to attract more people interested in this subject. And thank you, Lee, for the excellent presentation, very clear. It's always a pleasure to see you Rio de Janeiro. It's a long-term collaboration with Eduardo and many other professors here. I have a couple of questions. And first of all, I will make some, how to say, I will make some thinking about the problem you stated. Well, most of epidemiologists doesn't have the expertise on genetics and biology. Most of biologists doesn't have the expertise in epidemiology, etc. And this is a kind of new field that's going on, it's developing in the world. How do you see the movement to try to the global movement? I say in general of the researchers trying to make this interaction and trying to maybe to overpass this new border that is on the research.
Sure. Very simple answer. Please read my book. It's called. So I wrote a book called Molecular Epidemiology. It's old. I'm going to do a revision. But also, right now I'm in Rio because I'm teaching a course on molecular epidemiology in UERJ in Lisbon. And as you know, in Bahia, I've been teaching a 1-week course of molecular epidemiology for 15 years. Every year we do this course. So many Brazilians have taken this course. And so there's a part of Brazil, I think, that really know this, and they're beginning to do this. So this year is in July, we will have this course. If you're interested, you can come and, the inscription is open, so you can, sign up and take this course. It's in Fiocruz, Salvador. So there are people from EpiSUS come every year to do this. So people who are doing epidemiology, we understand the molecular side. So what we do in the course is we include epidemiologists and public health people, and then we include microbiologists. And on Sunday, the microbiologists learn to use, first we used to teach R, EpiInfo, and now we're going to teach R. Okay, so microbiologists have to kind of get exposed to it. And then the epidemiologists learn about PCR. Okay, so they understand the vocabulary of each other. And then we do the course for 1 week. So this year we're doing because it's the 15th year, we're doing 1-day symposium after the course. So we bring back many of the students who took the course. More than 500 people have taken the course so over the last 15 years. And then we're going to do a competition of the abstracts. And if the top person, if will be allowed to submit the abstract to some international meeting, and if it gets accepted, then we will provide transportation and the support to attend that meeting. So this is our way to do that anniversary. So if you are interested in doing something, you can submit an abstract and do that. But anyway, so that's just maybe one way. Maybe there may be other ways to do this, but in Berkeley, as you know, we teach this course, molecular immunology. So.
That's awesome. The abstract competition. And second question is, we also have a problem that since we are developing new methods to evaluate genetics and epigenetics and new ways to study this at population level, the matter of costs and field costs to evaluate these questions, what's the perspective is to getting cheaper or to develop new methods that are more expensive but more effective? How is this issue on the short term and long term?
No, it's a very good question. So, technology to do a lot of the genetic laboratory analysis, it's not cheap. But over the last, I would say, 5 years, even the whole genome sequencing, metagenomics, doing all this big data, genetic analysis have really come down in price. So, I think the price will continue to go down. But you don't have to necessarily do these big data genetic analysis. You still use, cheap, genetic methods. We do that in the US. We use, if we can answer the question. So the important thing is you have to ask the question first, the right question. If you can answer that question using cheaper technology, then you can do that. But, a lot of people want to do these fancy data analysis, but very often you don't have to do that. So the most important thing is asking the right question. If you have the question, then you can decide what to do. So, but the point I think is that many of these new technologies are really coming down rapidly in price. In Brazil, there are many people beginning to do this in Brazil. So the other thing is to collaborate with people who are doing that. So you don't have to necessarily learn all the details yourself. So you can, collaborate with people who are doing genetics, right? Work together. That way, you should know some things, but you don't have to do it by yourself.
Posso falar em português, Eduardo, você traduz para mim? Eu queria só voltar à discussão aberta para o Mário, da questão dos gestores, da saúde, em relação a se adaptar às VEBs, Embora eu não vejo nenhum problema disso. Primeiro, porque a maior parte dos gestores vem da área da saúde de alguma forma. E tem uma formação aí, juntando o que ele também comentou, tem uma formação tanto de epidemiologia quanto de microbiologia o suficiente para trabalhar mais ou menos na mesma densidade nos dois assuntos. Além disso, quem decide, não, em geral, não são os secretários, mas as áreas técnicas que têm formação de uma e de outra, frequentemente das duas. A questão, acho que também transcende esse aspecto de facilidade. Na verdade, a questão é outra. Aqui no Brasil, nós temos comunidade biométrica para a área da saúde, normalmente os municípios, dificultando a avaliação por áreas censitárias ou áreas menores, que é uma discussão grande toda vez que a gente trata com determinantes sociais da saúde, e principalmente quando trata-se de disparidades dentro de um município. Então, nós temos dificuldade de trabalho. A incidência é mais fácil, são dados frequentemente pontuais, que trabalham com base de dados cru, original, e dados de área somente a nível de município. E trabalhar com os dados para calcular o DALI não é simples se você não tem uma unidade básica, seja ela qual for, uma área censitária, microárea da unidade da saúde, de uma área de saúde da família, você não consegue fazer esse cálculo, simplesmente. Então, na área da pesquisa, bem, porque você já planeja para ter esse dado. Mas na área de quem está na gestão, nós não temos esse dado com facilidade. Isso dificulta muito e merece, inclusive, rever, a nível nacional, a atual política de banco de dados do país.
So, one of the the reason we do the work in Brazil is because Brazil is actually very good at or in the last 10 years, it's really advanced their surveillance systems. Okay, so in many countries, census tracts are not divided into AGSN and non-AGS. This is the first in Brazil. I think did this in 2005 for the first time in the census. Okay, so that's why we are able to do the research. If Brazil government did not do this, we cannot do this type of work. And so there is some attempt at the high level to try to, I think, understand disparity, try to quantitate disparity, and then we take advantage of what the government does to do more. So we could not have done this work in India, or South Africa, or many countries in the world.
Better than others. But as a matter of fact, it's more.
Of course, we're doing better than others, but of course, we need more granularity in the data to show intra-country, intra-counts difference.
Yes.
For instance, in Rocinha is at least 25 or 30 sensitive bases, but in health and health, we don't have this distinction.
Sure. So that's why the fact that we're able to divide Rocinha into different parts, right? You can use that data to then quantitate TB in more detail. So, and then that kind of data then maybe can be used by the government to do something. And so, we're providing the research data. Maybe they can do something. But yeah, you're right. They could do more. But it's encouraging that Brazil made an attempt to do this, because many other countries are not doing it. Even in the United States, we don't have this kind of way of dividing, these census tracts. It's very difficult to do this kind of study, even in the U.S., like income distribution, things like that. We use like a zip code or something, but we try to do this in the U.S. Same thing. It's very difficult. So at least Brazil is making an effort. It's better than before. Right? But you're right. I think it needs to do more. And I think we need to do the fact that we just got this paper accepted. So if it's published, maybe somebody in the government will look at this and say, okay, maybe we can do this with other diseases, other health conditions, not just infectious disease, but like chronic diseases, interpersonal violence. Maybe we can do this. I don't know. Oh, right. So yeah, Eduardo also published with Robbie Snyder, my student, also looking at more of a general kind of a health burden using the same AGSN non-AGS. So so we're able to take advantage of what the government has already done. And I think more people should do this. The researchers, and, we always ask the government to do something, but I think the researcher has to do something too. You have to do something at the bottom level. Take advantage of what the government is doing, so that then government will say that, oh yeah, you guys are doing this, we'll be able to do more.
Ok, alguém mais? Muito bem, então queria agradecer a todos a presença, enfatizar que tem aí, eu acho que uma lista rolando, quem quiser colocar já está aqui, e fiquem atentos aos nossos avisos. Queria agradecer muito a presença de vocês. I'd like to thank you, our guest speaker this morning, Leonardo, please.